Up to Faith Fueled, helping you to become the wise divine women that you've been called to be. Today, I have Laura James, naturopathic oncologist out of Washington State, and I am thrilled to have her here because there are just so many questions. We were talking behind the scenes about advocacy and pausing and gathering your thoughts, and there's just so much. Welcome to the show, Laura.
Thank you for having me, Dana. It's a pleasure to be here.
Thank you. So, why naturopathy and then why oncology?
Those are good questions. So I started naturopathic medical school 30 years ago, and that was after having worked in the conventional medicine field for almost a decade. So right out of college, I went into medical writing, grant writing for major medical centers, that kind of thing. And I really liked working in the medical space. And to be honest, it took me about a year and a half of taking my pre-med prerequisites, which I did not have in college because I was an English major in college,
Mhm.
to decide that I really wanted to go the naturopathic route. And the thing that really got me in that direction was nutrition. And, 35 years ago, there really wasn't a big conversation about nutrition in conventional healthcare. It was still an attitude of it doesn't matter what you eat, we're going to treat the disease, right? And we've since, I mean, we knew then that nutrition played a huge role in a person's health, and we know a lot more now in terms of clinical trials, which is always the gold standard.
Mhm.
So I made the choice to go to naturopathic medical school, of which there were only four accredited universities at the time. And it's been a really good fit for me philosophically. So that's how I got into naturopathic medicine. Was I wanted to be a doctor and had this choice between conventional and holistic, and I chose holistic.
Mhm.
Um, and then oncology, I sort of fell into. I had a clinical partner who was working in the oncology sphere, and her original partner decided to do something completely different. And so, my dear friend and colleague invited me to start going to oncology continuing education programs and start learning. And I was hooked. I was really hooked. And so that started the rest of my career, which has really been the bulk of my career in naturopathic medicine, working with patients with cancer. And
Mhm.
in the last 10 to 15 years, I've really honed in almost exclusively on helping women with breast cancer. So that's how I ended up where I am.
I love it. It all makes sense. Like once you start walking in that world, it all just makes sense. And now, I
Yeah.
mean, I'm coming out of a 10-year of thermography and
Mhm.
having all these questions when I'm doing these follow-up calls. And I'm like, I should probably know the answers to some of these questions. And I'm always like, there must be a test to test that somewhere. So that kind of
Mhm.
started my adventure with functional nutrition. And I have always been this person. I created this program like Touch Your Tatas because I was so surprised how many women do not touch their breasts,
Mhm. Mhm.
let alone let their
Mhm.
husbands touch their breasts. So there's so
Mhm.
much fear about it. So I'm on sort of that pre that where you are is like I'm just trying to educate women about breast health.
Mhm.
Like that's what
Mhm.
food's important, all those different things. So I love it. And I think the biggest question that I have is do you take women virtually? Do you see people in person? There are just so many women out there that need assistance. I think
Mhm.
it's sort of that it can be that adjunctive care, and they know in their heart and mind there's probably another way, but it's
Yeah.
just to educate.
Right.
Regardless of the
Right.
choice they may take, a lot of the things are adjunctive and they work in
Mhm.
conjunction with traditional therapy. So, how does that actually look in practice?
Well, it looks a whole bunch of different ways. And, I will say that naturopathic oncology is a very, very small field
Mhm.
There are only about 150 of us in North America, and that includes Canada. So
Mhm.
there are some terrific naturopathic doctors working in oncology throughout the provinces. I happen to live close to British Columbia, where I have quite a few colleagues who are fabulous. So if any of your listeners are in British Columbia, they're very lucky that they have some of cream of the crop people up there. I know you're in Ontario, and there's some great people in Toronto and environs, right? So for me, what I'm doing now is I am doing virtual consultations, which are recommendations that people can take to their team. And I'm actually in clinic for the summer. So I was invited to come into clinic. I had to take a little bit of a break due to some family things. And I've been invited into a colleague's clinic here in Bellingham, Washington. So I am doing in-person visits for the summer. I ran a huge oncology focused clinic for 20 years, closer to Seattle.
Yeah.
And that was a big thing. And I look back at what I did in my 30s and 40s, and I'm like, holy crap, how did I do all of that, right? So
Yes.
now it's lovely to be in a place where I can be invited by a colleague to come, see patients in her clinic. So for now, I'm doing some in-person consultations. It's a small practice, but I've had virtual opportunities for more than a year through my website. And my website is laurajamesnd.com, super simple.
Mhm.
But I also have some courses. I've tried to put a lot of information into easy to understand, easy to access courses, and I've addressed, pretty much everything because I think we were talking before we started recording about how overwhelming it is for women to receive a diagnosis of breast cancer. And there's so much information and there's so many decisions that have to be made. And women
Mhm.
feel like things are really out of control and out of their hands. And so I think there's so much empowerment that can happen when women understand their pathology report and what the imaging is saying and what their options are.
Mhm.
So I have some free videos. I have some videos that have a cost attached on my website, and I've tried to really encompass the gamut of understand your diagnosis, to understand what conventional medicine is going to recommend for you, what is standard of care, what are options in there, what do they mean, to some myth busting. There's a lot I call it the integrative medicine field.
Mhm.
Most people would lump it under alternative. There's also the term complementary. Alternative really is going to be a totally different plan for treating your cancer. Integrative is conventional care plus good quality naturopathic holistic care
Right.
knitted together to help the patient get through treatment, right? So I have a whole section about myth busting, what works,
Much
what doesn't
needed.
work,
Yep.
what's dangerous, right?
Very, very needed because it is a little wet, wild west when it comes
It
to
is totally
all of it.
Wild West.
Yeah,
Yeah,
very much
yeah.
so. And some things work, some things don't. Some things don't
Hmm.
matter at all, and
Hmm.
that's okay. But it's
Hmm.
allowing, I mean, I find it's just allowing the conversation. Like if
Right.
someone wants to ask the question, I'm willing to help them research it, or if it's right or wrong. So
Right.
it's giving them the space at least to research the place to be sort of
Hmm.
understood better because it is for them getting diagnosis or what was that they said or reading their radiology report or
Hmm.
all those different things. It's very hard and very
Hmm.
hard to discern what extreme it's at, and then the
Hmm.
hurriedness of the system
Right.
is,
Right.
that's just the way it's set up, and we're thankful for that. But it's that stepping back for a second and gathering your thoughts. right?
Yeah.
I would think,
I call it the breast cancer industrial complex. I mean,
yeah.
it is a, once a woman is diagnosed with breast cancer, it's this steamrolling machine that
Mhm.
comes at her. And there's so much urgency from the physicians, from everybody in healthcare. There's so much urgency. And even with a very complex diagnosis, a very complex cancer, an aggressive cancer, I think that women absolutely need to take at least a little bit of time
Yeah.
to sit with it
Yeah.
and decide what's right for her, because it really is her body, her choice,
Right.
right? And and so, she needs to be able to understand what's happening to her, what's being offered to her, build her team so that she has a team of people she trusts,
Hmm.
and build her support network, because it's not always the closest person who's going to be the best support person, right? It might be the cousin, it might be the neighbor, it might be, whomever it's going to be. But I also, so I encourage women to really try and understand what's going on so they know how to ask good questions,
Right.
and to really sit with it. But not too long, because evidence does show that women who wait too long to start treatment have worse outcomes. So there's this
Mhm.
window,
Is
there's
that
there's a
because
window.
the cancer has aggressed, or they just didn't take the right proactive approach? They
I'm
kind
sorry,
of ignored it. Sorry.
what?
Was that because they ignored it and they waited too long and they
Yeah,
didn't take a proactive change?
correct,
Okay,
correct.
yeah. Because I'm
Yeah,
thinking if you're pausing for a second, I'm always, you should be changing your diet. Like,
yeah, yeah. But you still need to be on somewhat of a rapid track.
right.
I mean, women who, I believe the most seminal piece of literature shows, and I'm not 100% on this, but I'm pretty sure it shows that women who wait 6 weeks or more to start treatment have worse outcomes.
Oh, okay.
And that
Interesting.
that is, I believe, all stages of disease. What literature has not been able to prove is women who choose to have some integrative medicine, they don't have worse outcomes, right? But it's studying integrative medicine like studying nutrition. It's very hard to really evaluate the continuum of what people are doing in in the whole, right? Meaning,
Mhm.
like, you'd have to have someone in a black box and have them just receive one intervention and nothing else to be able to really have good critical research about nutrition, for example, right?
Right, right.
Because you can't control for all the factors. And integrative medicine is such a huge topic, right? You really have to look at all the little pieces, right?
Right.
So it's hard to have really robust research, one way or the other, which is frustrating for me because people want to know, right?
Hmm.
But there's a lot we don't know.
No, exactly. And I mean, we really, I don't think like say at the Hope Center or in the clinics in Germany or
Mhm.
those types of things where it is kind of a retreat controlled environment, we're not really seeing research coming out of there.
Correct.
Yeah,
Correct. Research costs money, you know.
it does.
I
It
mean, it's
does.
just the nature of it.
No, exactly, exactly. And I mean, to me is that I will research that further, that 6 week window, because I think that's really important and I did not know that.
Hmm.
I'm always like,
Yeah.
I'm in my mind, I'm thinking like, give yourself 3 weeks, 2 weeks, 1 week even. Do one
Yeah.
week. Just pause for a
Yeah.
second. Make
Yeah.
sure your mind, your body, your soul is ready for the choice that you've made. Get your ducks in a row and
Hmm.
then or
Hmm.
find that local person practitioner. So what do you mean by a team?
So I think women need, it's kind of an A team and a B team, right? So they're the A team. I'm thinking through, do I want to call the medical team A team, or do I want to call the support network A
I
team?
guess it depends on relationships,
I think it
honestly.
depends on relationships.
Yeah.
Yeah. But from a medical standpoint, if women are really interested in an integrative plan, and from my point of view, what I help women do is help them make decisions about their conventional care, what care to, what are their options. And then everything I do naturopathically is to support those options that she chooses. Surgery, chemotherapy, radiation, anti-estrogen therapy, all the things, right? And so, I believe, and this is what I feel has been borne out in my practice over the last 25 years, is that women tolerate conventional treatment better if they have an integrative plan. And what I'm trying to do is build resilience
Hmm.
during that process, because so much of that process is also psychological, emotional, it's the mental game,
Yeah.
right? And that's where the support team comes in, is with the mental game. So, the A team being the medical team, and it's going to be some combination of medical doctors in the oncology care center, wherever someone is, plus the naturopathic oncology professional, or if you don't have a naturopathic oncology professional that you can access, a naturopathic doctor, or a doctor who has a lot of education in this naturopathic oncology space.
Hmm.
And there are MDs and ARNPs and other folks who have prescriptive rights,
Right.
who have done a lot of education in the naturopathic oncology sphere. So those people do exist. I also think acupuncture can be extremely helpful for people, especially if they're going through chemotherapy.
Hmm.
It's a great tool to help manage nausea and vomiting, pain, insomnia, those things, hot flashes. Nutrition is a huge piece, but I also look at where people are in their conventional trajectory. Because when
Right.
someone's going through chemotherapy, taste buds change, people can be really nauseous, people might be throwing up, people might be losing weight, whatever. It can be hard. And what I don't want to do with a patient is make them feel guilty for not checking all the nutrition boxes,
Right.
right? When they're done with conventional treatment, chemotherapy, radiation, then we can really dig into the nutrition piece. And people have more energy then, people have more taste bud capacity, right?
Right.
And appetite, right?
Yeah, and it's important. Like there's got to be a give and take in a team effect, and even for
Mhm.
the person to not is the worry or the regret or the of not being able to achieve what they set out in a goal that can be
Mhm.
more worrisome for the person than need be, and that's where
Right.
that statement of give and take and ebb and flow, and we understand our what we want to do, but we have to have you know a little bit
Yeah,
of flexibility in all of this.
exactly.
Yeah.
Exactly. And the other thing about the medical team that I want to say is, and I'm not 100% sure how it might work in Canada, but in the US, um, a woman absolutely can change providers within a system. If
Mhm.
she's assigned a provider that she just really doesn't feel good about, she can ask for a different provider. And I think it's incredibly important to work with providers that you trust.
Right.
And you're going to know in that first visit, right? You're going to know if it's a good fit with a provider. And, they all get together every morning and they talk about cases and they help each other out. So, in terms of knowledge base, if you're in a system, you're going to get that knowledge base. So in many ways, it really doesn't matter what provider you have from a clinical standpoint, but from a relational standpoint, it makes a lot of difference,
Hmm.
because women want to feel heard, right? Women want to tell their story. They want to be listened to. They don't want to be classified as difficult because they're asking questions, right? And different providers are able to provide that or not, right?
Right.
So in the States, a woman can ask for a different provider if she doesn't like the one that she was given to begin with, right?
Right.
So that's also an empowerment piece, right? So A team, the A team, those are going to be the clinical decision makers, right? And the clinical people who are going to be acting on the woman's wishes. The B team, which is also equally important, so I hate to call it B, but the other team is going to be the home support network,
Right.
and that can be whatever collection of people. But what I encourage women to think about is, how do they want to be helped? Because people are well-meaning when a loved one has a cancer diagnosis. And a lot of women don't, number one, don't know how to ask for help because they're always the ones giving help and being a caretaker, right?
Right.
So when it comes time for, mom or grandma or whomever to be taken care of, it's a hard transition. And I think that we receive in very individual ways. There's this whole concept of love languages
Hmm.
and how we receive love. And, the way I give love might not be the way you necessarily receive love, right? So for a woman to kind of sit in, how does she receive love and care? How to ask for what she needs from whoever the people are on her support team, right?
Right.
I think that can really help improve her emotional state. Because, I think a lot of times people are well meaning and they think, oh, I'm going to bring food because she doesn't have enough energy to cook, right? I'm going to bring food for her family. And, on the 20th casserole, like that's too much, right?
Mhm.
And maybe what the woman really needs is for a neighbor or a friend or whomever to come in and do the laundry and put it
Yeah.
away for her,
Yeah. Yeah.
you know?
Is that
But
something, do you
that's
go
not
over
the
love
first thing.
language in the information? Like
I'm
in your,
sorry?
do you go over love language
No,
at
I
all?
just refer people to a website.
Okay. Yeah.
I'm pretty sure it's called fivelovelanguages.com, I
Yeah.
think. There's also a quiz you can take on, I believe, Psychology Today.
Hmm.
And, it's something that's easy to find online
Oh,
is
absolutely. I just thought it was
what's
I
your love language?
that's a very interesting perspective on how to, learn how to ask and give when you need care, and for even caretakers to sort of recognize
Hmm.
that that's sort of how that works as well. And even, I mean, gosh, we should be doing it as when we have kids and families and get married and all this, but
Right.
hindsight, right? The book's been around
Yeah.
since the 80s,
It,
70s
it's
or
an
80s.
old book. Yeah,
It's
it's
a
an old
very old book.
concept. Yeah, it's an
Hmm.
old concept. But I think, particularly women who are sick, you
Yeah.
know, they have to come to a place where they are asking for help, they're allowing themselves to receive it, and, to crank it up a notch, not feeling guilty for asking,
Right.
right? And that's a big one. That's a really big one for a lot of women. So many, I mean, how many women do you know, or, yourself, who say things like, I just don't want to be a burden, right?
Yes. Yep.
You know,
All the
it's like,
time.
I love you, be a burden. I can handle your burden,
Hmm.
right? That's
Hmm.
what the friend says. That's what the partner should say, right?
Right. Right.
Um, you know, but women feel guilty for having needs. And that has to change. I mean, not just in the breast cancer sphere, but that has to change.
It does. It does. Yeah. I think even in the as the aging population happens as well, and a lot of the sort of 70, 80-year-old women grew up to be very strong, independent,
Hmm.
powerful, women, and
Hmm.
that's going to be very hard for them to allow people to help them and or, you know, age well. I mean, they're going to age well anyways, but it'll come to a point that they need help. And
Hmm.
so we all have to learn how to ask and to even foresee the things that need to happen as well. So,
Right.
in
Right.
any situation. So
Yeah. Yeah. Exactly. Yeah.
that's amazing. That's a really great way, really great topics. I mean, honestly, like really great the studies and the love language aspect. So in the what are some of the frequently asked questions that you get from women?
I get
The
lots of
top five.
questions.
Top five.
Probably, well, let's start with the top two because they're on
Yeah.
the top of my head. The number one question I get when people, I mean, pretty much like sit down across from me is, what should I eat?
Mm,
That is hands down the number one question.
yeah.
And, I tell them what I told you, which is, well, where are you in this process? Right.
Right.
Um, and so it starts with an answer of where are you in this process? And then it goes to maybe we need to do some labs and see what your blood sugar parameters look like so that we know how much carbohydrate you should be consuming if you're pre-diabetic, that kind of thing, right? So we
Mhm.
can dig in there. Um, and generally I recommend sort of, I call it a modified paleo Mediterranean diet.
Right.
I don't recommend anything draconian. I want people to eat real food, and generally, I want people to spend their money on good quality food as opposed to supplements, right?
Yeah. Yeah.
Um, I think the second question I get from women who have breast cancer is, what do you think about the anti-estrogen therapy that they're recommending for me? That
Hmm.
is definitely up there in the top five. And, we know 70% of women who are diagnosed with breast cancer have an ER positive breast cancer. So it's a large number of those women who have that question. And anti-estrogen therapy is split into aromatase inhibitors, which are predominantly given to women who are menopausal, and
Hmm.
tamoxifen, which is predominantly given to women who are premenopausal.
Right.
Both of them block estrogen in different ways, right? And, women don't want to lose their estrogen, right? Estrogen affects every aspect of a woman's body and brain.
Hmm.
So it's a very salient question, and it's a very personalized answer.
Yeah.
It depends on the case, right? Um, I believe we have good integrative strategies to support women who are on those drugs.
Hmm.
In terms of what we can do integratively as an alternative to those drugs, it's a much harder situation.
Yeah.
The drugs are effective and they yield good long-term outcomes for a reason, because they're drugs,
Right.
right?
Right.
So it's a complex question to answer, but I would say that's the second question I get.
Well, yeah, absolutely. And I get that asked all the time. So now I know where to send people to go. Because I'm to me in the back of my mind, I'm just like every cell has an estrogen receptor. Does that does mean that every single cell will not receive estrogen, or does it miraculously know where it's to send it or
Yeah,
not absorb it? So it's
yeah,
that, and now that the black box warming has been removed, and there are far more research studies that are coming out with the importance of estrogen, then this even muddies the water even further, I would think,
yeah,
and women would really be questioning those therapies.
yeah.
Do you find?
Absolutely. Well, and I also have a lot of conversations with women about estrogen therapy,
Yeah.
and it's a sticky wicket. I mean, it's a really sticky wicket.
Yeah.
And so, I think there is good research that supports both ways. I'm gonna mitigate my my
That's
commentary
good.
like
No, and I think so. And I think now that there is information out there, you
that. Uh-huh.
can go research, you can
Yep,
understand. But
yep,
as I
yeah,
remind people, I'm always like, you have to ensure that your foundation is good. Like your
mhm,
stress is managed, that
yep,
you're absorbing your nutrients well, you're not
yep,
toxic, like your minerals are solid, you
yep,
don't have any microbiome issues, you're
Yeah.
eliminating things. It's, you're pooping at least once a day or twice a day. These are really
Yeah.
basic things in drinking water.
Right. Right.
That doesn't happen with women. And then that conversation can play. If you don't have any
Right.
of that set
Right.
up,
Right.
it doesn't matter how much hormones you give yourself, it's not going to work. So,
Yeah, exactly. No, that's a
mhm.
really good point. And, I think I want to really emphasize the individuality of every woman who has breast cancer. And not only is the woman an individual, but her cancer is individual to her.
Mhm.
And one of the things that drives me crazy is when I get questions and, patients who come in and they just lump cancer into the bucket with every other cancer, and their experience with cancer may be an uncle or a cousin or a brother or someone who had to receive chemotherapy for whatever cancer it was or whatever, and they died, or had a horrible time with chemotherapy. And so, I think this is really prevalent. There are a lot of people who don't necessarily understand that cancer is like 7,000 different scenarios, right? And there are 7,000 different ways to treat those 7,000 different scenarios. So,
Mhm.
every woman is individual, every pathology report is individual, every treatment recommendation is individual to a point, you
Right.
know. Um, and it depends on what the treatments are, right? And we're getting, I mean, one of the beautiful things that I'm seeing in my lifetime as a practitioner is the more personalized medicine approach from the conventional side, because we have more information about genetic things, genomic things, and we have drugs to target those, right? So
Right.
so medicine in general is becoming more personalized,
Mhm.
which is great. Does it make us closer to cure? Yeah, maybe a little, you
Yeah.
know. Um, but the personalized approach is where medicine needs to be, and
Mhm.
then I try and further personalize it with, all the things I do. But I have to understand the personalized pieces from the conventional standpoint, right? To make
Right.
appropriate decisions.
Do you think they're using the genomics aspect from what chemotherapy or what types of medication will work the best for that cancer? Like, it used to be the onco test out of Greece, so and now we have the DNA information now, which is
Right.
amazing.
So there are a bunch of different tests that fall into that genomic category.
Mhm.
You're talking about chemotherapy sensitivity testing, which, to be honest, has a lot of clinical problems. And so, the research is mediocre. And so the best testing that we have is testing that looks at the tumor tissue and what targets might there be in the tumor tissue that then maybe there are drugs or clinical trials for.
Right.
So for someone who's in treatment, that can really be life-saving testing. For someone who's stable, so we have to talk a little bit about stages of disease in breast cancer, right? Because women have a shot at cure with early disease, right? The earlier you catch disease, the better chances you have of cure, right? Later stages of disease, you have less opportunity for cure, but what you're doing is living with a chronic disease and you're looking for stability, right?
Okay. Okay.
And so, in higher stages of disease or recurrent disease, we're looking for stability, right? Long term stability. And so, the testing that providers are really sort of starting to use now is circulating tumor DNA testing, not circulating tumor cell testing. They're two different things. But circulating tumor DNA testing can tell us, is there circulating tumor DNA in the bloodstream?
Mm-hmm.
And if the answer is yes, then we're given a sort of quantity of that and then can make some treatment decisions. If the answer to that question is no, then we've got good stability,
Right.
right? So the ctDNA testing, I think, is a game changer for people who are dealing with higher stage or recurrent disease in that respect, because it does happen. You know, women have no evidence of disease, right?
Right.
And so that can be, instead of being on treatment for long periods of time where there might be side effects, right?
Mm-hmm.
Difficult side effects, you can sort of have a window into what's going on biologically, right?
So, and
Um,
that's just the DNA portion of things. And the other test with the floating cells, is that now becoming this sort of opportunity to monitor from like, ring the bell, post, you're fine, you're gone. Are they using that now to monitor 2, 3, 4, 5, 6, 10 years out yearly now?
so the ctDNA tests are, like I said, they're sort of, I'm encouraged that more providers are starting to adopt that kind of testing.
Right.
I think 5 years from now, we're going to see it be pretty commonplace, but it's still not commonplace. Patients have to ask for it.
Hmm.
Um, Circulating tumor cells are not something we look at.
Okay.
So we're looking for a signature. We're looking for this tumor DNA. Is it there? So those are two different types
Yeah.
of tests.
Hmm.
Um, the genomic testing, looking for different types of mutations, that is very much in practice. And I'm talking tests like Foundation One and Guardant 360. Those are two of the most popular tests, I believe, worldwide.
Yeah.
I know for sure in the US, those are ones that are utilized, and those are looking for genomic information and drug targets, right? So that changes the course of treatment. And, we're talking all conventional treatment here. We're not talking any kind of other treatment.
Hmm.
But most of those tests aren't necessarily employed unless someone has recurrent or later stage disease. They're not typically utilized when people have very early stage disease, because I think oncology believes that we do have a shot at cure and here's how you get there, you know?
Yeah, yeah,
Um,
yeah. There has to
right.
be. I mean, you have to start somewhere and you have to have that
Yeah,
faith in that
exactly.
the things
Exactly.
that we have
Yeah.
are going to be a solution. So,
Mhm.
just for those who don't know, stage 0
Mhm.
breast cancer is.
Is carcinoma in situ,
Mhm.
either ductal or lobular. And a stage 0 carcinoma in situ is really like a clump of cancerous cells that have been found on imaging generally.
Right.
And that means that they are encapsulated. So those cells have not spread beyond a very small border. And typically, with a carcinoma in situ, you can get rid of it with surgery. And then the recommendation tends to be radiation on top of that to sort of clean up any detritus that might be around the site of where the tumor was,
Right. Right.
right?
Are they
So that's stage
using
0.
are they using the oh my gosh, the freezing in stage 0
Cryoablation.
cryoablation? Thank you.
Cryoablation, at least in the States, has really only been given approval for women over 70.
Okay.
Um,
Makes
I
sense.
think it will quickly become utilized in younger women. But it's been given approval for women over 70. So, and I mean, cryoablation is great. I mean, it's just zap. So it can be, I don't want to say less invasive, but a different kind of invasiveness than a lumpectomy.
Right.
Right. So, anyway, yeah. So for very small disease, right,
Hmm.
cryoablation is an option. What's the deal in Canada? Do you
Oh, we
know?
don't have cryoablation. That's for sure. We have to go out. Stage zero, same thing, in situ, or if it's
Mhm.
starting to spread, same lumpectomy option or chemo radiation, depending on what's going on. Then
Right.
they'll check or take biopsy of the lymph nodes, and off you go, right? And
Right.
then it depends, right? Like if you have ductal carcinoma, then that sort of speeds up the pace. And can you speak into that a little bit more when you
Sure.
have the ductal
So,
carcinoma or DCI? Yeah.
stage zero I described.
Yeah.
Stage one is when those cancer cells that were in an encapsulated
Mhm.
location start to start to pop out of their boundaries. And so that is a still very local, relatively concentrated tumor site that can
Mhm.
often be treated with lumpectomy, depending
Mhm.
on where it is, right, in the breast. Um, every breast surgeon I have ever worked with, and I've worked with teams up and down Western Washington, every breast surgeon I've ever worked with is always going for the best cosmetic result for the patient.
Right.
So, I've seen beautiful work done by all of these surgeons who really, really are trying to preserve the breast, the natural breast for the
Right.
woman. Um, Sometimes a tumor is in a place where there's just no choice. There's
Yeah.
no way to get a good cosmetic result. There's no way to get the tumor without taking the breast. And those are often tumors that are very, very deep and posterior to most of the breast tissue, right?
Mhm. Mhm.
And much, much larger tumors, it's very hard for surgeons to get a good cosmetic result if they have to take a great big chunk, right? So, but all the breast surgeons I've worked with have been amazing surgeons, and so with a stage one tumor, which is still on the smaller side, right? Because part of the staging has to do with size of the tumor. Um, for the most part, people can have a lumpectomy, and then radiation is what's going to be offered. So this is still very local disease. Stage two disease is when the tumor gets bigger and starts to travel a little bit.
Mhm.
And so you can have stage two disease with um, lymph node involvement. And that's really when chemotherapy starts being on the table,
Yeah.
right? I mean, sometimes with stage one disease, depending on its characteristics. But
Right.
usually with stage two disease, there's going to start being a conversation about chemo, and that's what freaks people out. Um, Stage three disease is more progressed, so
Mhm.
down the lymph node chain.
Right.
And then stage four disease is the breast cancer cells are everywhere,
Correct.
um, right? And they're in potentially the bones, the lungs, the liver, the brain. And I want to make a little distinction because I actually had this conversation yesterday. Someone asked me about a patient who had breast cancer 20 years ago, and now she said bone cancer. And my question was, is the disease in the bone a breast primary? Is it a breast cancer cell that's in the bone, or is it a
Mm.
bone primary? So, this is something, just a little piece of understanding for your listeners. When someone has breast cancer and it spreads to the bone, to other places, it is still a breast cancer cell.
Mm-hmm.
It
Mm-hmm.
originated in the breast, it travels.
Mm-hmm.
If someone has bone cancer, it is a sarcoma. It is a totally different kind of cancer cell, totally different pathology, totally different way of treating it, right? So that's a I think for some people maybe an academic distinction, but it's
Right.
important in this conversation of not all cancers fall in one bucket, right?
Right,
And
exactly. And I would assume the doctor's going to test for that, or they're just going
yes,
to,
absolutely.
yeah, exactly. Like,
Absolutely.
absolutely, they're
Mhm.
going to see if it's a where the original,
Right.
if it's
Right.
origin based, or if it is a new cancer.
Right, right.
Yeah.
And so, I think there's a little bit of a cautionary tale there because this particular patient that was being discussed was someone who had had a bilateral mastectomy 20 years ago when she was diagnosed with breast cancer. And when women have particularly bilateral mastectomies, there's no imaging follow up that happens once they're
Mhm.
done with their initial treatment. And the bone is the most likely place for breast cancer cells to metastasize to.
Yeah.
So, here's this poor woman who's 20 years out from her breast cancer diagnosis, not a whole lot of breast cancer follow up in between, and she ends up with
Mhm.
metastases in her bones, which may or may not have caused pain. Like, I don't know enough about that case to know if she had pain and she ended up going in and she had imaging and they were like, holy crap, there's cancer all over her bones, right?
Right.
Um, Metastases to the bone will generally cause pain, but not for a while, not for a
Yeah.
while.
Yeah.
So there's this gap in surveillance, and maybe that's where thermography really can fill the gap. But there's
It,
this gap in
mhm.
surveillance for this for
Mhm.
this narrow population of people, but I think it's also really important.
Yeah, I think with our blood work, there must be clues within the blood work that say there's something off, right? And we just
Sometimes,
don't, yeah, we just don't know enough to look at that in that
yeah.
perspective. And I think that's where we need to learn to advocate better for ourselves in understanding. Thermography to me is that sort of let's look at the entire chaos of the body.
Mm-hmm.
Let's understand like your physiology or metabolic process. It's
Mm-hmm.
definitely not a diagnosis. I yeah, it can't because it just
Mm-hmm.
can't. And there's no defiant determination in it, anyways. But it is so true that there's this big gap. Like even for women who've had mastectomies, I have them come in for thermography, and then our discussion talks about okay, scar tissue and the liver support and stress management because those are the things that we see
Mm-hmm.
in that. So I'm really hopeful for the advances in monitoring that are going to come down the line. There's
Mm-hmm.
just so much great research that's happening right now.
Yeah.
And again, therapies for women as well, when it even comes with the new discussions with estrogen and progesterone and even testosterone in helping women no matter where they are in every stage. Doesn't have to be oncology stage of things, but at least we can research it now and at least we can talk about it now. Whether it will ever happen for women to have any additional hormone therapies during breast cancers is a great question. And it's a very individual question again, but
Mm-hmm.
at least doctors can talk about it now
Mm-hmm.
and really
Mm-hmm.
look at those options. So
Exactly. You asked me early on in this conversation, sort of how I got here and why I do what I do. And one of the reasons that I love working with patients with breast cancer is because it's everything about women's health.
yeah.
It's everything and more. And
Mhm.
when I was working in my really big clinic down near Seattle, I had so many patients who just stuck with me for years after their initial breast cancer treatment. And I always say I'm sort of a primary care physician for women who've had breast cancer because I have that filter, right? I have that filter in place. I know what a woman has been through with her breast cancer diagnosis, and I know how that plays out long term. And, to be honest, for so many women who have breast cancer, it's more likely they're going to die of heart disease than it is they're going to die of their breast cancer. And
Yeah.
so, and that's often really reassuring to women too. Like, okay, I know what to do for heart disease, right? The heart is a pump, right? And so, I've really enjoyed that because, the woman is not just a breast cancer patient, right?
Yeah.
She's a woman with complex medical needs and potential risks, right? And
Right.
so, it's really important to keep that in mind, is all of these pieces: hormone balance, cancer prevention, heart disease prevention, and the good news from a holistic standpoint is almost everything we do for cancer prevention is also going to help prevent the other, major diseases in our Western world, right? Heart disease,
Yeah.
diabetes, and dementia, right?
Yeah. Yeah.
So, we can kind of cover all the bases.
Mm-hmm. It's a fine line. Like I'm finding that sure, breast cancer is in that scary question for a lot of women, and it's in the mind, that type of idea. We don't think
Uh-huh.
about heart disease in that level, even though more women die of heart disease. But the dementia risk, I think that's
Hmm.
almost just as scary as breast cancer.
Yeah,
So
exactly.
these are all different, avenues that I love researching and kind of diving deep about. But again, you're right. When you're trying to prevent or trying to clear or trying to help the body heal from a breast cancer diagnosis, you're helping the entire body from head to toe,
Hmm.
right?
Hmm. Exactly.
Yeah.
Yeah. Yeah. So, I think people lose sight of that when they are, given a number on the conveyor belt of cancer care, right?
Yeah. Yeah.
So,
It's all very fascinating, and I love the research will continually be keep changing, right?
hmm.
As the, AI models sort of come into play, and projection ideas and testing and all these different things. So,
Yeah, right.
yeah.
Exactly. So,
So, do you have a QT scanner over in Seattle?
Um, good question. There may be one in Seattle now. I mean, I don't practice in Seattle anymore.
Mhm.
I practice up north in Bellingham, Washington.
Right, right.
And so I'm not quite as connected. But, my understanding is the QT imaging is excellent, but insurance doesn't cover it.
Right.
And, it's not ready for mass consumption yet,
No,
right?
no. Are you finding that
Unfortunately.
women are having the ability to get ultrasounds and more preventative idea in the West Coast?
No, the West Coast is not as open-minded as you would expect it to be, unfortunately.
Mhm.
Um, Most women, I mean, there are a handful of places that will do ultrasound without mammogram, and it's only a handful, like a small handful. Most women are shunted into the mammography track,
Mhm. Mhm.
which, mammography does save lives.
Yep. I
And, you
even though I'm
know,
a big sonographer, I'm still like it's completely two different things.
hmm.
And at some point you may need the yes or no.
Yeah.
And it's not the mammogram, the one or one every 3 years or whatever you choose is the issue. Perhaps it's the repetitiveness or the continued, but it's the inability for from that test to step back and consider health,
Uh-huh.
right? It's the
Uh-huh.
health of your body that brings you to the pinnacle tipping scale that I think gets ignored. And that's where thermography, I think, plays an adjacent role with that so
Hmm.
that you can step back and say, oh, my gut is not good. My teeth are not good. My hormones are out of balance. My thyroid is funny, but the blood work says it's fine. And that's where naturopathic care, right, really plays
Yeah.
a beautiful role in that so
Yeah.
that all opportunities of healing are presented to every single person. So,
Yeah.
yeah,
Yeah.
love
Exactly.
it.
I think, we've seen recently what has happened with the menopause conversation and hormone replacement therapy. And a lot of that comes down to advocacy, right?
Mhm.
A lot of that comes down to a lot of women asking a lot of questions and pushing for their own benefit, right? For their healthcare
Right.
benefit.
Right.
Um, there are lots of advocacy groups related to breast cancer. I think in general, women tend to still be somewhat marginalized in the healthcare space. And, we need to shout loud about what we need
Hmm. Hmm.
and what we want to see in the healthcare space. And there was, I'm sure you're familiar with the Lancet, the
Hmm.
extremely famous medical journal that comes out of, um, I believe it comes out of England. And they had a commission, right? Like you always need a commission to come up with an idea, right? And it's this huge document basically saying we've lost the human connection in cancer care.
Yeah.
Duh,
Yeah.
right?
Thank you. Yeah. Thanks for
Um,
stating the obvious. Yeah.
right,
Yeah.
exactly, right. We needed a commission of 25 muckety mucks in healthcare to say we've lost the health in healthcare, right?
Hmm.
And I think, women are naturally more inclined to promote the softer, more humane side of whatever
Right.
the conversation is, right?
Hmm.
And in breast cancer, that's part of what we need, right? We need that human connection. We need that individualization of care. We need a space where women can ask questions, but also have more support than they're getting, right?
Right. Yeah.
And unfortunately for women with a breast cancer diagnosis, like they're tapped out and overwhelmed and tired and all of those things. And so, it takes a lot of effort to
Mhm.
see those changes. But I'm hopeful that in my lifetime, might not be my practice lifetime, but my lifetime, that we see some really positive humanistic changes in our healthcare. So.
Yes. So, just to sort of touch on something, because I know we're almost running out of time, but how are you finding the approach with younger women in their 30s that are having the breast cancer? Do you find that they are looking more so because they're far more, sort of educated in what they can research and they gather the information well, but we're seeing a surge in lower age breast
Yeah,
cancers.
we are.
But what about is I already, you see the surge in breast cancers for younger women, but then are you seeing the surge in HPV cancers as well in sort of the craziness of the world? As stress increases, I find all of this increases. So,
I think that's true. I think, and this is my own conjecture, but I think, we've grown up in a very polluted environment, a lot more
mhm.
polluted than our parents grew up in, right? And I think that we have suffered from that physiologically with cancer incidence. I
Right.
think that's part of why younger people are being diagnosed at younger ages. Um, and, in terms of younger women sort of navigating things, I do get a lot of inquiries from younger patients. Um, but I also see a lot of kind of do it yourself stuff.
Yeah.
The younger women are incredibly adept at finding information online, but they're also, I think, very swayed by, frankly, people who don't know what they're talking about on the internet.
Yeah.
Um, and that concerns me, that really concerns me. Um, and so, but then there's the other kind of flip side of young women who really don't want anything to do with the conventional approach, right?
Yeah.
And And so then that's a tough conversation to have, particularly when a young woman has children. And, I really have to look her in the eye and say, you need to be here for your children. You
Yeah.
need to do it all. It's not always just about you, unfortunately, in this scenario,
Mm-hmm.
right? When you're 60 and you're diagnosed with breast cancer, you have a little more wiggle room there. But if
Yes.
you're a 30-year-old mom of a 4-year-old and a 6-year-old, your priority has to shift,
Right. And
right?
that six, and then that
That makes it
6 week
harder.
window becomes really important.
Yeah.
Like there's
And it
no
just
pulling
makes
back.
it harder,
Yeah.
right? Because you want it to be all about you. And in so many ways, it should be all about you, but
But
you've
you
got
can't.
kids,
Mm-hmm.
right? You don't want to leave them without a mother, right? That's a
No,
hard
exactly.
conversation.
It is a really hard conversation, I think, with any cancer, when
Yes.
you have younger cancers, and that is that perfect, you need to pause. You need to make sure your ducks are in a row. You've got
Yep.
care for everybody. That's
Yep.
where that the casserole train becomes important for them, and that team effect certainly. And it's a little more aggressive, I understand, with younger women. So it's not a 6 week, it's like 3 weeks. You've needed to make those decisions and get everything rolling, regardless of the choice you make. But you have to work aggressively with that and stay
Right.
on top of it. Because I find, with my sister's brain cancer, I don't think we spent that time in between her second, the second manifestation of it. I don't think we were checking. So there's always like this monitoring of things that need to occur between things. So yeah,
Yeah.
then it shows up and it's like, oh my
Yeah.
gosh.
Yeah.
So
And it's, honestly, I mean, any oncologist would say losing the younger patients is
it's the hardest.
devastating, right?
Yeah.
It's
Yeah.
devastating.
So
So,
you had beginningly spoke about you think there's 150 or so naturopathic oncologists in North America.
yep.
Is there a list somewhere in the
There
world?
is, yeah,
Right?
there
Yeah.
there is. So we have our own association. It's called the Oncology Association of Naturopathic Physicians,
Yeah.
and it's onc.org. And you can search for a doctor, within 50 miles, 100 miles, 200 miles, whatever of you.
Perfect.
And like I said, in Canada, I know there are people in, I believe, all the provinces.
Hmm.
And one thing I want to say about the naturopathic oncology work is that we do have a board certification process.
Yeah.
So it's a tightly regulated, distinction. Um, and that's why there are only 150 of us. So if a naturopathic oncology professional is not available for someone, they live way up near the Arctic Circle or whatever, there may be a naturopathic doctor close by, and the naturopathic doctors do have access to us, right?
Right.
So I always try and make myself available for people's primary providers in some way.
Hmm.
Um, there's, definitely a cost attached to that because it's my time to review a case. But
Right.
I'm always happy to talk with people's primary providers and then have the primary provider implement a plan.
Right.
So, you can find the people to work with, if you're living out in the sticks.
Yeah, I think if you're creating that A team and you need sometimes having that one-on-one relationship or the in person
Hmm.
has so many great merits to it, to be honest. So it's
Hmm.
like that. And then if you get into your world, it's that connection practitioner to practitioner. And I,
Hmm.
I really appreciate the sort of surge in IV clinics in the world now. And
Hmm.
that's where the naturopathic doctor can also work in conjunction. If they don't
Hmm.
have their license to do, therapies, then they can refer and have that relationship. And it is this beautiful new network of healthcare providers that are out there in the world.
Hmm.
It's a beautiful thing, and even with nutritionists now, I'm a huge advocate of getting people to work together and create the team, share the report, share the report. Like
Hmm.
it's it's all. yeah, the person who's ill has to remain the focus for everybody, right? So.
Mhm. Yeah, exactly. Yeah.
So it's laurajames.com, and you have little
It's
free resources. Oh, Laura
it's
James ND.
actually laurajamesnd.com.
Okay.
Yeah. laurajamesnd.com, and I'll send you, all the information so that you
Yes.
can put it in the show notes. But I have a lot of information on my website. I'm making some changes later this year, so things will shift around a little bit. But people can submit an application. I can communicate with them about what options might present themselves. I've got some free videos, I've got some paid videos. I do a fair amount of public speaking.
Hmm.
I'm potentially available to come talk to groups, larger groups. I love sharing my expertise with people so that they make good choices.
Oh, exactly. And I think it's all about getting you out there so that you can, and even if you aren't available, you have that network of people in
Hmm.
their local regions,
Yep.
and so
Yeah.
it's this beautiful um, landscape of health care that's client focused, that advocates for clients,
Hmm.
and that brings people together, giving them, their choices that they want to advocate for, and feeling confident in the choices that they make, right? So they
Hmm.
don't feel lost and alone and rushed and hurried during these little, this sweet period of time, and they feel they have control over the situation.
Yeah, exactly. Exactly. And I hope to have my book published in early 2027, and then that will be another resource for people. I'll let you know when that comes out. But that will be a very cheap resource for people that hopefully will bring some clarity to them as they're going through this process. So,
That's beautiful. I was going to ask if you have a book because
not
it's a,
yet.
it's a
It's
lot
taken
of
me a while to get
information.
there.
It's a lot of information to get out there,
Yeah.
right?
Yeah.
And it's
Exactly.
then how is it being presented and how is it being digested by the clients? So for
Yeah.
sure. Well,
Yeah.
thank you. So
Anyway,
I finish with one thing. What is a word of wisdom that you've held yourself true to, or a phrase that you've like held to that brings you through life?
as a clinician, I would have to say I'm doing my best.
Hmm. That's all you
Yeah,
can say. That
that's all I can say.
is all
Yeah.
you say. And what do you find that you often give as a word of wisdom to your clients?
Give yourself some grace.
Mhm. Yeah, yeah, that's really important,
Yeah.
right? Because nothing's
Hmm.
perfect, and it's nothing is a failure, and nothing is perfect, right? It's an ebb and flow
Exactly.
in things, and we have to have grace in that situation. Thank you
Yeah.
so much, Laura, for being
Thank you
part of
for having
this.
me.
We could keep talking about a million things, but
Yeah.
time is valuable for you. And I thank you so much for sharing your wisdom today, sharing your passion to help women with breast cancer, and creating this world of advocacy and knowledge for not just now, but honestly, for generations to come. Because you're just setting the stage for the opportunities of further research and further naturopathic doctors to continue the good work that you've been doing as well.
Yeah. Thanks for having me, Dana. It's been really a
Yeah,
pleasure.
it's a pleasure. Thank you so much for joining us. You'll be able to find all the information in the show notes. And again, laurajamesnd.com to find all of the information that you've been seeking, especially if you have a breast cancer or any cancer diagnosis. Thank you so much for joining us today.
Thank you.